Hello everyone, this is the third video in the series of management of severe acute malnutrition. So in this video, we'll discuss treatment of associated conditions in a patient with severe acute malnutrition. So commonly patients with severe acute malnutrition present with eye problems. So if the child has any signs of vitamin A deficiency, give vitamin A orally on days 1, 2 and 14. If the age is less than 6 months, you give 50,000 IU. If they're between 6 to 12 months, give 100,000 international units. In older children, give 200,000 international units. If the first dose was given in the referring center, then treat on days 1 and 14 only. If the eyes show signs of corneal clouding or ulceration, give the following additional care to prevent corneal rupture and extrusion of the lens. So instill chloramphenicol or tetracycline eye drops 4 times a day as required for 7 to 10 days. Instill atropine eye drops 1 drop 3 times a day for 3 to 5 days. Cover with saline soaked eye pads and bandage the eye. If a patient with severe acute malnutrition presents with severe anemia, blood transfusion should be given in the first 24 hours only if HB is less than 4 grams per deciliter, HP is 4 to 6 grams per deciliter, and the child has respiratory distress. In severe acute malnutrition, the transfusion must be slower and of smaller volume than for a well-nourished child. So give whole blood at 10 ml per kg slowly over 3 hours. Then together with the blood you need to give furosemide, which is a diuretic, at 1 mg per kg IV at the start of the transfusion. If the child has signs of heart failure, give 10 ml per kg of packed cells because whole blood is likely to worsen this condition. Children with severe acute malnutrition with edema may have redistribution of fluid leaking to apparent low hemoglobin, which generally does not require transfusion. Monitoring the pulse and breathing rates, listen to the lung fills, examine the abdomen for liver size, and check the jugular venous pressure every 15 minutes during the transfusion. If either breathing or heart rate increases, breathing by 5 breaths per minute or pulse by 25 beats per minute, transfuse more slowly. If there are basal lung crepitations when enlarging liver, stop the transfusion and give furosemide at 1 mg per kg IV. Of note is that do not repeat transfusion even if the HB is still low or within 4 days of the last transfusion. Then skin lesions in kwashiorkor. So zinc deficiency is usual in children with kwashiorkor, and their skin quickly improves with zinc supplementation. So in addition, first you give your zinc supplementation. Together with that, you bath or soak the affected areas for 10 minutes per day in 0.01% potassium permanganate solution. Apply barrier cream such as zinc and castor oil ointment, petroleum jelly to the raw areas, and gentian violet or nystatin cream to skin sores. Avoid using nappies so that the perineum can stay dry. Then if the patient presents with continuing diarrhea, you treat giardiasis. Where possible, examine the stool by microscopy. If cysts or trophozoites of Giardia lamblia are found, give metronidazole. Treat with metronidazole if stool microscopy cannot be undertaken or if there is only clinical suspicion of giardiasis. Then if the patient is lactose intolerant, diarrhea is only rarely due to lactose intolerance. So intolerance should be diagnosed only if copious watery diarrhea occurs promptly after milk-based feeds are begun, and if the diarrhea clearly improves when milk intake is reduced or stopped. Starter F75 is a low lactose feed in exceptional cases. You can replace milk feeds with yogurt or a lactose-free infant formula. Then reintroduce milk feeds gradually in the rehabilitation phase. Then when you suspect osmotic diarrhea, so this is usually suspected if the diarrhea worsens substantially with hyperosmolar F75 and seizures when the sugar content and osmolarity are reduced. So in these cases, use cereal-based starter F75 or if necessary a commercially available isotonic starter F75. Introduce ketchup F100 or RUTF food gradually. Then, if you're suspecting the patient has TB, perform a Mantox test, take a chest x-ray. Then, if these are positive or TB is strongly suspected, treat according to national TB guidelines. So that's all about severe acute malnutrition, management of associated conditions. Thank you.